Hello, I'm Dr. Kim Yongjin. With the widespread of use of implant treatment for edentulous patients, various bone materials are launched in the market for bone augmentation to improve the implant placement environment in patients with bone deficiency. Main ones are autogenous bone, allograft, xenograft, and alloplast. In this lecture, let's look at what bone graft material need to be chosen depending on clinical environment. This is the contents of this lecture. First, autogenous material, allogenic, xenogenic, alloplastic materials. And I prefer to use a sandwich bone augmentation, which will be discussed before I close. First, depending on the origin, there are 4 bone graft materials. Autogenous bone from the same person, the patient, allograft, human to human, xenograft, animal to human, using bovine, porcine, or horse bone. Alloplast uses synthetic bone. Autogenous bone material can be classified into block bone or particle bone depending on how they are harvested. Allograft can be divided depending on how to remove antigenicity. After removing it, depending on how to treat the particles, the bones can be in different categories. Next, xenograft. It can be categorized depending on how the organic material is removed, depending on the method of removal. Alloplastic material can be in different categories depending on the composition. Dentists believe that bone graft material itself is turning into the patient's bone, but that can be expected only when autogenous bone is used. Clinically, allograft, xenograft, or alloplasts are used more than autogenous bone. So when we do bone graft GBR, the role of bone graft material is providing mechanical support to the membrane, maintaining ideal alveolar bone contour around the implant. That's all they're used for. If you use a certain bone graft material like TFTBA with higher BMP contents, you can differentiate mesenchymal stem cells into osteoblasts, but that role is minimal. Let's look at autogenous bone material. The autogenous bone material is considered as the gold standard, very good. Because we use the patient's own bone, it is free from infectious disease. If it has a lot of bone marrow, the cancellous bone, the live osteoblasts within the bone is grafted together, so direct bone regeneration from inside of the bone material can be expected. But the amount that can be harvested is limited, and you need an additional surgical site. So the donor site mobility would give discomfort to the patient. So clinically, this is not a preferred method, and we use a lot of commercial bone materials. Next, allogenic material. This is the processed bone from donated corpse. There are many different allogenic materials in the market. This material, it is very important to remove the antigenicity. It is similar to organ transplant that requires the removal of antigenicity. There are broadly 2 ways to do it. Highly concentrated irradiation or rapid freezing. Commercially, rapid freezing is something we can easily use. FDBA, freeze-dried bone allograft. Some company uses highly concentrated irradiation, which is called ICB. Optimount Tissue Bank is providing that product, but in Korea, FDBA is the one mostly used. FDBA can be in the powder form or a chip form, depending on the size of particles. If it is bigger than 1 millimeter, it is a large particle, chip type, and if it is less than that, it is a powder type. The allogenic material can be processed in a block type. It can replace the autogenous bone. In some specific cases, the FDBA, demineralized freeze-dried bone allograft, can be used. There are two types, the FDBA, demineralized freeze-dried bone graft, and DBM. After demineralization, gelatin or collagen can be added for ease of use. That is called DBM. To the DFDBA, certain carrier is added. So gel type or putty type can be made. Both of them are demineralized. We need to keep in mind that allogenic material includes organic material. Antigenicity should be removed. Why demineralization? To use a certain component in the organic material. BMP is the main one. It stands for bone morphogenic protein. In 1965, Professor Urist of Orthopedic Department of UCLA injected a certain component of protein, the organic part, after demineralization into a muscle which developed bone. Bone is made in a non-osteogenic site. We call it ectopic bone formation. Certain protein component makes bone where the bone is not supposed to be made, so it is called BMP, bone morphogenic protein. Where are they? BMP mainly exists in the extracellular matrix. It is in the organic matrix of protein. So, after demineralization of allogenic material, protein would be exposed, and BMP, the bone morphogenic protein, is released a lot. That is the purpose of using it. But when we do GBR or bone augmentation clinically, DBM or DFDBA are not recommended to be used alone because of demineralization. They are highly resorbed and they do not have sufficient space maintaining capability. Anyway, autogenous bone or allograft, the human bones can be used, and the healing pattern is like this. In the anterior region, cortical type allograft is used for the GBR after 5 to 6 months. In the secondary surgery, you can see it is healed. It is completely replaced by the autogenous bone of the patient, and the regeneration has occurred. So please keep in mind this healing pattern. Next, xenogenic graft material using porcine, bovine, or horse material. There's a bovine base, porcine base. These can be the broad categories. More importantly, when we use the xenogenic material, we need to remember that organic component, the protein, should be removed. Xenogenic protein shouldn't be spreading in the body. So the process of protein removal can be done using heat treatment. As I said before, autogenous bone or allograft, the human bone, when it is grafted, osteoclast would resorb them and it is replaced by patient's own bone. When xenograft is used, the resorption takes a long time and alloplasts are hardly resorbed. When you choose them, you need to consider whether it has coarse structures or porosity or the roughness of the surface to induce the new bone formation. You need to make a careful selection for better clinical bone regeneration. For successful bone regeneration, we need to consider 3 things. Cells, only osteoblasts can make bone. But xenograft or alloplast do not have the cells, so we can expect the cells to grow bone with autogenous bone graft. We need signaling molecules that can activate the mesenchymal stem cells to osteoblasts. Such molecule is BMP, which is not in the xenograft or allograft. For scaffolding, porosity and the pore structure is important. Scaffold factors need to be considered when using xenograft or alloplast, which are not easily resorbed. We use alloplast or xenograft because the cancellous bone of a cow or pig is similar to that of human being. As they are structurally similar, humans' osteoblasts can adhere to that. So structural properties need to be considered. As I said before, when we use xenograft, protein must be removed through heat treatment. Depending on the temperature, we have high and low temperature treatments. If it is higher than 600 degrees Celsius, it is high, and lower than that, it is low temperature treatment. When we use xenograft or alloplast, ultimately, we want to make them similar to the cancellous bone of human being so that osteoblasts can adhere to the xenograft. Let's look at the cancellous bone of a human. 65% of it is pores, so it has macro and micro pore system. If you look at it closely, it looks rough like the surface of an implant. Osteoblasts like the rough surface, therefore all implant companies try to produce the roughness similar to the human cancellous bone. The same goes for the bone materials. The bone materials that you use, if they are not connected with each other, the pore system is closed. They are not easily saturated with the blood. The blood cannot penetrate into the bone materials, so the area where cells can adhere to would be small. But if pore structures are interconnected, similar to human cancellous bone, through the capillary vessels, the blood can go into the structure of the bone material, increasing the blood holding capability, so vessels can grow into the bone material. So a good bone material should have the porosity structure that is similar to human cancellous bone. I talked about removal of organic material through heat treatment that's burnt out. Depending on the temperature, the basic structure would get varied. The purpose of using the low temperature treatment is to remove the organic material while maintaining the bovine or porcine cancellous bone similar to human. What about high temperature treatment? Just like PFM fabrication, after porcelain buildup and sintering in the furnace, recrystallization occurs, so that happens in the bone material as well. That closes the pores. So with the high temperature treatment, the residual organic materials would be removed 100%, but the structure of the cancellous bone similar to natural bone is lost due to recrystallization, and the pore system is closed. So the blood cannot be held and the cells cannot penetrate inside. So the representative low temperature treated bone graft material is bios. Cow's femoral cancellous bone is treated at low temperature, which has very similar cancellous bone as human. Ostem's AOS is very similar to that. Bone graft material based on bovine bone. Like BIOS, it is treated at low temperature. The structural similarity to human is maintained. As you can see, human bone is very similar to AOS in terms of the pore structure. Macropores on the surface and the macrostructures are very similar. So osteoblast can get attached to it very easily. It is similar to human cancellous bone physically and chemically. The structural similarity is maintained due to the low temperature treatment. If you compare various products with high temperature treatment, the pores would be closed or the pores would be reduced in number because of the recrystallization, and the surface area would be reduced. The blood retention is lowered. If you compare AOS with other xenograft materials, the blood retention capability is lowered if it is treated at high temperature. If a good bone material like AOS is grafted in a critically favorable environment in terms of blood, over time the blood would be retained and self-aggregated. That makes handling very easy. From the surgeon's perspective, in doing GBR, it is easy to handle the material with good pore structure. From the patient's perspective, bone regeneration is made favorable as retained blood increases. So we need to consider the pore structure when we choose xenograft. Choosing a low temperature treated material is better. In terms of the healing pattern, the xenograft is not resorbed. As I said, autogenous bone and allografts are resorbed and replaced by patient's autogenous bone, but xenograft is not resorbed at all. A little controversy over human bone versus xenograft. Autogenous and allogenic bone is replaced by the patient's bone, but the resorption rate is very high, about 30%. It depends on whether cortical or cancellous bone is used. The resorption rate is very high. However, if you use a xenograft, it is not resorbed, but exposed implant can be covered with a GBR, but direct osseointegration between the graft material and implant cannot be expected. As you can see, xenograft material is used in the posterior region. It cannot be replaced with the patient's own bone around the implant. The bone implant contact ratio, the BIC, is very unfavorable, and this is what I think. The exposed implant can be covered with GBR. Rather than using one type of bone material in order to grow bone near the implant, exposed or dehiscence part of implant should be covered with a regenerative bone. AOS or xenograft needs to be used in the outer side. So two different healing pattern bone materials are mixed together. So in conclusion, allograft, xenograft, which one is better or worse? That is not the point. The healing pattern of them is different. So you need to apply them in an appropriate place or indication. Next, alloplastic material. The material has three types depending on the components. Materials are fabricated in a lab or a factory. It's not from natural bone. First, if you look at the components of the alloplastic material, first, beta-TCP, second, pure hydroxyapatite, the third one is BCP, biphasic calcium phosphate. I will explain it simply. Beta-TCP, the chemical formula is very simple, so it can be resolved very fast. Due to fast resorption, it is not good for the GBR in aesthetic region due to the instability of the volume in the long run. It can be used in a self-contained defect for fast bone regeneration, or allograft is hard to obtain. But locally, allograft can be used quite a lot, but I don't really like to use it. Next, pure hydroxyapatite. As you can see, the chemical formula is very complicated and stable. It takes 6 to 8 months for resorption. It is very slow to be resorbed. Very fast resorbing beta-TCP is combined with slow resorbing hydroxyapatite. Through the sintering, the heat treatment, they are combined into one phase, resulting in biphasic calcium phosphate. Hydroxyapatite and beta-TCP are not combined physically, but fused with heat treatment. This is called the BCP family. QOS plus of Ostim is the representative brand name. QOS is based on hydroxyapatite, so it is slow to be resorbed. Conclusions of bone graft materials. There are three mechanisms of bone regeneration: osteogenesis, osteoinduction, and osteoconduction. Osteogenesis, osteoblast in the material is grafted, and from the inside of the graft material, directly bone formation is achieved. This is the bone regeneration pattern we can expect among the cancellous bone containing autogenous bone graft material, that is, iliac bone graft. The mechanism of osteoinduction is to differentiate the mesenchymal stem cell to osteoblasts. Like the BMP previously mentioned, DFDBA contains a lot of BMP, so with that, osteoinduction can be anticipated. However, most bone graft materials, DFDBA, allograft, xenograft, and alloplasts, use osteoconduction. Osteoconductive graft materials do not have a special effect. It is just a scaffolding. Osteoblast surrounding area would go into the graft material, and the bone is made inside. There's no role of the graft material. It is just maintaining the space. So when we use xenograft or alloplast, we need to consider the pore structure and porosity. Autogenous bone is considered as a gold standard, very useful. However, as I said before, it is hard to harvest, and it's not used often because of the discomfort due to the donor site morbidity. I'll talk about autobone collector that can be used to harvest the autogenous bone easily next time. Allogenic bone is processed from corpse, so we need to use a reliable tissue bank. Hans Biomed was the first tissue bank in Korea. The show-us from Ostim is pretty good bone. And xenogenic bone is non-resorbable, so the xenograft sintered at low temperature is better. The same is for alloplastic bone. We need to consider porosity and pore structures. Lastly, let me talk about the sandwich bone augmentation. I talked about the characteristics of two graft materials. The healing patterns of a human bone and xenograft differ. So for the GBR that covers the exposed implant, around the exposed implant, to maximize BIC, autogenous bone of the patient should be used, autogenous bone or allograft. But they are easy to be resorbed. Therefore, for long-term and stable alveolar bone contour to be maintained, xenograft or hydroxyapatite-based alloplastic materials need to be used. Rather than mixing two graft materials, you need to use them like sandwich. After understanding different healing patterns of each bone graft material, you need to use it in a proper place. Let me show you a clinical case. Two implants were placed due to horizontal defect, and the buccal threads are exposed. For the GBR to cover the exposed implant and to augment the alveolar bone, near the implant that is exposed, we need to use the allograft that can turn into the patient's bone, and on the outer side, the augmented alveolar bone needs to be maintained for a long time using a non-resorbable xenograft in a layering like this. This is the sandwich bone augmentation technique. Till now, we have talked about the healing pattern and the healing mechanism of various graft materials. Today, we don't cover all the cases with one type of graft material. We clinically use many different graft materials in different places. To choose proper graft materials, we need to understand the healing mechanism of the graft materials before we apply that clinically. I hope this master course has been helpful in your choosing proper bone graft material. Thank you very much.